But I almost feel I'm blinded because if I don't have, Prospera, I really don't know where in the spectrum are these patients falling, right? Are they high risk, low risk? I really cannot put my hat onto this. It's like where it is, right?
I see.
And it helps me kind of put that thing, okay, I mean, these are patients that are now in the low risk, and I feel comfortable with whatever immunosuppression they're on.
Hi, I'm Dr. Phil Gauthier, a transplant nephrologist and Senior Medical Director at Natera. In this episode, I'm very excited to be chatting with Dr. Sanjiv Anand. Dr. Anand is a transplant nephrologist and the Medical Director of the Living Donor Transplant Program at Intermountain. Dr. Anand will discuss his experience with Prospera and how it has led to improved clinical outcomes. He will also review the results of the ProActive registry and how this has aligned with his clinical experience. Finally, he will talk about how early increases in Prospera can lead to the diagnosis of subthreshold rejection. Hi Sanjiv, how you doing?
I'm doing good. How are you doing, Phil?
Great. You enjoying the conference so far?
Yeah, it's going great.
All right. So I'd like to talk to you about your experience with Prospera and the ProActive study today. So tell me, how long have you been practicing transplant nephrology?
So I've been practicing transplant nephrology for almost over 10 years now, and I've been at Intermountain for the last 10 years.
Okay. What do you like best about transplant?
Well, what I like best about transplant is, you change somebody's life for good, and you actually improve their survival. Yeah. And that is the best part about transplant, is you give somebody, the gift of life, and that's great.
Yeah, that's great. And I understand you've been using Prospera in your practice, is that right?
Yes, we have been using Prospera, since whenever it was launched, essentially, and we were part of the ProActive, study, as you mentioned. And now we have, good experience with it, and we continue to use it going forward as well.
Okay, and so what has been your experience with Prospera in your practice?
Yeah, so what we realize is that, out of the current, scheme of things that is available, including serum creatinine and other tests that we routinely do, Prospera outperforms all of them in identifying patients who are high risk for rejection. And I think that is the key here, because essentially what we are trying to change is long-term outcomes. And, to get there, you need to be able to identify the patients early rather than late in the game. The problem is that when you identify somebody late, then the dishes are done. You can't do much about it. You can't change the outcome with the treatment that we have available right now. But if you were able to identify earlier, theoretically, you can intervene and you can possibly change the outcome. And that's what I like about Prospera.
Okay, so can you elaborate a little more? How does Prospera help you identify rejection earlier compared to other biomarkers?
Sure. So, Prospera is, donor-derived cell-free DNA. Mm-hmm. So basically, essentially, if it's low, which is a cutoff, so median values for patients who are non-rejecting is like 0.24 or so. But if you are at high risk of what we call as allograft injury, mm-hmm. then your Prospera will be high. And typically, rejection thresholds have been set at 1%.
Right.
So if we notice that's a patient that we are following with serial Prospera draw, and it's starting to uptrend, mm-hmm. that's when our alarms go off, saying that basically this patient needs more heightened close follow-up, more surveillance, maybe need to optimize the immune suppression. And let's say if we were to do a standalone value, of Prospera on someone, just a snapshot without any previous values, it becomes challenging, but in the right context, if it's higher, greater than 1%, then you can identify rejection. Serum creatinine has lagged as a biomarker for identifying rejection in these cases. So most of, in the ProActive study, about 45 to 50% for-cause biopsies were based on donor-derived cell-free DNA. And that tells you is that most of the time we were able to identify these patients just because the Prospera was elevated rather than the serum creatinine. And so essentially what we do in our practice is that, so if somebody's Prospera is going up, mm-hmm. and it's not yet at the threshold where you quantify rejection, what we would typically do is that essentially optimize immunosuppression. So we look them at more carefully. If the cell subdose has been reduced, we'll increase it. if if they're having high intra-patient variability of tacrolimus, we might consider switching them to belatacept or envarsus or other therapeutics. So essentially intervening, and it gives you that, that focus that you didn't have before. Is basically now you can pinpoint on that patient and say, and we actually have a watch list is what we call.
Okay.
So all of these patients, what we do is in our EMR, we kind of flag them. So when the coordinators are reviewing their lab, they know that this patient is on that watch list, and I need to be more cautious about, making sure that immune suppression is optimized. They're getting the labs routinely checked. So it just, kind of segregates patients into high risk and low risk, and then you can follow them more closely. Also, to your point, about identifying rejection. So what we have seen is that if we do a biopsy based on elevated cell-free DNA, that correlates very well with, molecular microscope and diagnosing early, antibody-mediated rejection, which is the part of trifecta study that also Prospera is involved in. So that ties things together for us, and we also use molecular microscope on all our biopsies. So then we identify rejection very early, especially the early AMR, and as you know, antibody-mediated rejection is associated with bad outcomes, especially chronic ones that you identify late in the course. So our hope is that when we are identifying early, we are intervening them by optimizing immunosuppression and increasing more maintenance immunosuppression, that we are going to dampen the immune system response and essentially the downstream cascade of fibrosis. So, that's how we have been using Prospera.
Well, that's really interesting. And can you discuss molecular microscope a little bit more for our viewers that may not be familiar?
Sure. So molecular microscope is essentially, so when you do a kidney biopsy, the traditional kidney biopsy has been, you take the biopsy, the core, and that's, sent to the histology lab, where it's stained and then looked under microscope. This is slightly different. What happens is you take a core and you put it in a specimen that's called RNA layer, and you send it to the molecular microscope lab. Over there, what happens is from the tissue, they look at the RNA transcripts that are upregulated in cases of rejection. And these have been studied on prior samples and validated. So essentially, there's a huge database that this has been studied on and validated. So essentially, they're looking at these gene expressions. Now, to understand how it is different from the traditional histology is that, the first thing that happens when you're going to encounter rejection is gene expression. And then the second thing is going to happen is tissue changes. So essentially, you may not see it in the tissue, but you may see it in the gene expression. So, when my patients tell me is that what really it means, so I tell them that, so histology is like your roof is leaking, right?
Okay.
But molecular microscope is the roof is not leaking, but if you were to scan the roof, you can find a patch where it's going to leak. And that's exactly what it is. It's upstream rather than a downstream damage that you can see. So essentially, then you can act really upstream because you know that the genes are upregulated, and there's for reason that these genes are upregulated. It could be either low immunosuppression, right? Or it could be, patients have developed, de novo donor-specific antibodies, and so those are the reasons. So then, essentially, that's what molecular microscope does. It looks at those gene sets, see it's upregulated, and then it classifies based on the gene into T-cell mediated rejection, early AMR, full-blown AMR, or no basically rejection. And that is really helpful for us as clinicians because we see this discordant result between molecular microscope and histology, but a concordance between Prospera and molecular microscope mostly, and mostly in the early, or mostly to diagnose antibody-mediated rejection. And as a clinician, and when I think about patients, it really empowers us to be able to see things very differently than what we were doing 5 years ago, right? 5 years ago, we were banking on creatinine and the traditional histology. But now we are looking at molecular markers and hoping for early intervention to change the outcome.
I see. So it sounds like you're saying that molecular microscope is an earlier indicator of trouble than traditional histology.
Yes, yeah. It gets, it diagnosed rejection early in at least, I mean, most of the studies have shown, and that's why there's the discordant, especially in the antibody-mediated rejection, and also for borderline T-cell mediated rejection, where there's a lot of discordance, where your, the transcript, basically the transcriptomics or the molecular microscope says that there is no TCMR, but histology might say borderline TCMR. And that is great because you have to look at both sides of the coins.
Right.
Essentially, one side is that, okay, I diagnose early AMR, which is not on histology, so that's giving extra treatment to the patient, right?
I see.
The other side of the story is that if you have a borderline or a TCMR BAMF1A, where molecular microscope refutes the diagnosis, and then if you elect not to treat those patients, you're actually, basically improving outcomes still, because you're not
Right,
you're not going to have
steroids,
downstream infectious complications with all that. So as the first molecular microscope and the Prospera, when we did back in 2017, we got the results and all that, kind of scratching our heads, right? What to do. But so essentially we had a patient, second kidney transplant patient. We got a Prospera, was elevated, and creatinine was fine.
Okay.
And then we got a molecular microscope done on the biopsy. The molecular microscope came as early acute antibody-mediated rejection.
Oh, okay.
And then we got a DSA drawn, and he was DSA positive. These were de novo DSA. He was second transplant, but was maintained on immunosuppression till he got to the second transplant. So now, we elected to treat, despite histology showing no AMR. Okay. Now, and then we did some, maintenance immunosuppression modification, increasing it, added some IVs, etc. When I'm in this conference, I got a message from my coordinator that he came to see us, and he's 6 years out now.
Oh, great.
And we are hoping, can we readjust immunosuppression and all that. And the first question I asked was, what's the Prospera, right?
Oh, right.
Because it helps me know where he's settling at, right? Because the coach, I mean, he's not having any infectious complication, but he was just wondering, can we dial some of the cell sub dose down, etc., and all that. But it's 6 years out, and he's young, and he's enjoying the graft survival, right? So if I would have missed that, then I would have diagnosed it, but most likely 3 months later or 2 months later, right? And then it would have been a worse outcome.
Yeah, and that's fascinating, because what you're saying is, even though the traditional histology was negative, you treated just based on the molecular findings, and that led to a better outcome.
Yeah, exactly.
And it sounds like you've also been using Prospera on this patient to monitor him post-treatment.
Yeah,
Is that something you do routinely?
Yeah, we try to do that, and essentially we try to do on these patients who had one episode of rejection, to basically see what happens post-treatment, and to see if there is what we call as these, relapses of rejection, right? So essentially they get into this quiescence phase, but then to see if, they would kind of go up and down. And if they do go up, then that also is a trigger that either we need to re-biopsy, because as a center we don't do follow-up biopsies on these rejection. Right. Number one reason is our geography is pretty wide. So, being in Utah, we cater to, Wyoming, Idaho, Nevada, down south Colorado. Right, yeah. So it's a big area. So getting a patient to come here for a biopsy is very challenging and tricky. And also it's very inconvenient for the patient, because they usually are doing an overnight stay. We try to do these to minimize the cost burden, we are trying to do them outpatient biopsy. So essentially that means that they have to come and stay the night, right?
Oh,
and then they have to have someone with them who's going to drive them back, the same day, or essentially stay the night. And if, let's say, the treatment, we need to do any treatment, we're waiting on molecular microscope, that's another 2 days, so they might have to come back and all that. Right. So that's one of, very strong arguments for us to basically keep using Prospera in the post-treatment phase, to be able to monitor these patients very closely and to see, especially with the wide geography, I call it another set of, coordinator, basically.
Right. Oh,
that helps to, monitor these patients and to be able to identify if they have this blip or if they have the relapse of rejection.
I see. And so I would assume also that you're able to avoid biopsies for cause using Prospera for the same reasons.
Exactly.
Is that right?
Yes. So that's very important. And I think, yeah, audience need to realize that is that what happens is that at times, the creatinine is up and your Prospera is normal. I don't biopsy at all.
Wow.
Because of the high, negative predictive value that it has, right? So
Right.
basically, if you have a low Prospera, you're almost certain that there's no rejection that you're dealing with. And, so we accept a lot of AKI kidneys that go DGF and all that. And if we were to do, so we do, so creatinine, let's say, at 2 months is at 2.2 or something. And let's say the mate kidney was discarded. So we don't have information on the, the
Right.
mate kidney. So now we are going off, okay, creatinine is 2.2, and, it was a high, and we do also eplet mismatching, and it was let's say a high eplet mismatch. Now you're worried about rejection, right?
Of course.
So you want to make sure they're not rejecting, so I always get a Prospera first. Because again, these are fresh post, it's like 6 weeks, but then again, you don't want to take them to biopsy and have a bleed and all that. So essentially, if the Prospera is low, I don't biopsy. I just say we need to be patient here. We just need to follow the course, right? That's what it is. So that changes practice pattern quite a bit, and it actually is very helpful to the patients.
So can you put a number, like how much has your use of biopsies decreased since you've been using Prospera, would you say?
Yeah, I mean, it's hard to quantify, but what I would say is that, let's say for all acute kidney injury patients that I get, or serum creatinine, as I alluded to previously, are in the DGF mode or slow graft function mode and is not optimized. On those patients, I would say that if the Prospera comes low at 80 to 90% of the times, we have avoided biopsy.
Wow.
Yeah, so I mean, recently we had a case, and PRA 100% patient who got a kidney basically flown across, right? So cold time was 30 hours, right? So, but there's no other offer, right?
Right.
Because he's 100% PRA. We got the kidney in, of course, delayed graft function 3 weeks later, and we had the procurement biopsy, so time zero biopsy also. So we knew kind of what we were dealing with. So we get the kidney 3 weeks later, he's still on dialysis, making some urine, but still 4 weeks later is still the same story, right? Then we said, and it's an intra-abdominal kidney. The reason is it's a second transplant, so they couldn't put it, and of course vascular disease. So in that case, we totally avoided the biopsy. We went for a Prospera. It was low. We said we're not dealing with rejection. We have to be patient. It was high cold time, AKI kidney. We're going to expect it's going to be slow.
Right.
So I would say in all these patients, especially in the acute kidney injury, if it comes low, almost 90 to 100%, I don't biopsy them.
That's great.
Take away from it.
So I'm dying to know, did the patient recover kidney function?
Yeah, it did.
Excellent.
So
That's great.
yeah.
So let's talk a little bit about your specific surveillance protocol. So can you describe your current surveillance protocol? And first of all, right off, do you surveil everybody or just some patients?
Yeah, so all new kidney transplant patients do get surveillance till about month 13.
Okay.
And then it's kind of based on where they're falling, based on the data that we have.
Right.
Then we would elect in some patients to basically kind of phase it out or follow them more closely. So that's our protocol. Now, prior to getting into the details of the protocol, I want to take a back step and see how we came to that.
Okay.
So essentially going to the ProActive study. So in the ProActive study, what was demonstrated was, so essentially, there was about 1,600 patients. 422 patients were selected because they had a biopsy done. And in the, biopsy event, that was kind of the sentinel event or, your event, prior to the biopsy, there was 1 to 3 cell-free DNA or Prospera samples in these patients. And they had 18 to 36 months follow-up.
Okay.
Based on that data, what was found was that if you're not rejecting, so there was a cohort that had no rejection, your cell-free DNA across, so if you look the months prior to biopsy, so, month 0 is biopsy, -1 is, the month prior, and then you're going negative, back in time. So if you start in month 6 and you go all the way to biopsy, if you're not rejecting, your, Prospera is going to be the same value essentially. It's going to be low.
For the whole 6 months.
All 6 months, okay? But if you are a person who has T-cell mediated rejection, okay, it's going to be kind of stable for, -4 months. And then at 2 months prior to the biopsy event, it does this abrupt rise. So the biopsy event itself is month 0, but prior to that, about 2 months prior to that, it starts to do that abrupt rise.
Huh.
And of course, at the event itself, it's really high. Okay. Now, antibody-mediated rejection is really, where cell-free DNA comes in much handy. And what it is showed that is that basically, if your biopsy again event is 0, time month 0, as far as if you go to -4 months, it actually starts to increase there. So there's a sudden, there's a sudden gradual increase of Prospera that starts to happen at month 4. And it kind of creeps up slowly, uptrending till the event itself. And that, so that was kind of the basis when we looked at that data. Basically what we gathered from that or gleaned from that was that essentially what it tells us is that, cell-free DNA goes up even prior to the biopsy event itself.
Wow.
So it's essential to basically monitor these patients and see actually if you can optimize immunosuppression at the window of opportunity rather than wait for the event to happen at biopsy and to diagnose a rejection.
Wow,
So that's where we came from. So based on that, when I see that data, what I gather from that is that I feel like there are certain trigger points in the patient's transplant journey that led to that elevation in Prospera, right? And as a clinician, very common trigger points for us is reduction in immunosuppression, right? So then we looked at our protocol and we saw which are the time points where our center as a standard of care is reducing immunosuppression. So we found, month 1, okay? Prednisone goes down to, 5 milligrams, okay? So that's a major change, okay? But the challenge is that if you were to do a Prospera at month 1, you're not going to see the change because biological change happens later after you make a medicational intervention, right? So so then we said, okay, the first one we are going to do at month 2, okay? Because there's going to be lag, right? You make the change and also realize that most transplant centers follow patient very closely, right, for the first 4 to 6 weeks. So nothing goes wrong in those weeks except some surgical issues, right? Mostly you're very well managed and your tacrolimus is followed twice a week and all that.
You're seeing them all the time.
Yeah, exactly. It's like, it's like, it's like marriage, right? You're just seeing them all the time. But then at basically, on the second month is when we do the first, draw. And then what happens is month 3 clinically, we lower their tacrolimus level and that's standard of care, right? So people will go from 8 to 10 to 6 to 8. And that's what, we have done. Now, some patients will do fine, right? But some patients with that reduction might develop a de novo DSA or might develop, tubulitis or some injury, right? So in order to identify that, then we said we need to do at month 4.
I see. That
right?
makes a lot of sense.
And then what happens is that after that, what happens is that usually about, month 3 or so, as I said, we have a wide geography. We hold them for the first 4 to 6 weeks local, but they start going out to their homes, which is, the right thing to do. They get, and then they're being followed intermittently by, community nephrologists. And then what happens is that I've seen a trend as usually 6 months, somebody will lower the CellCept to like 500 BID, mycophenolate, or, whatever they are on, the anti-metabolite. And it's just kind of the thing to do, right? And then,
so we do.
Yeah. So then we said, okay, that happens and that's beyond our control, despite we following them closely, but this happens. And there's no way for me to pick where it's going to happen. So we said, okay, we are going to do the Prospera at then month 7, right? And then the same thing happens at month 9. These are kind of the sentinel events in clinician mind that, hey, 3, 6, 9, we need to do something about immunosuppression. And then we said, okay, then we're going to monitor at the month 10. And then the same thing happened at the month 12, where, as we all know, standard of care, even for a transplant center, we'll reduce tacrolimus to 5 to 7.
Yep.
And many centers would even reduce CellCept at that same time. So then we do at month 13. Now, if during this journey we find that somebody's cell-free DNA is really low, like 0.2 or something like that, then we really feel that this is a low-risk patient, right? So then we are very comfortable that this patient, does not need such frequent draws. We can go to every quarter, we can even go to every 6 months and see how they do. But if somebody starts to show an uptrend, that's the one we start focusing on and say, you know what, this patient needs to come to see us frequently. We need to see this individual. But this individual is good, we are fine. So.
Yeah, that's a very thoughtful protocol. So do you look at the recent cell-free DNA before you make the next drop in immune suppression? And do you alter the changes in immune suppression based on the cell-free DNA values?
So we look at cell-free DNA when we are faced with a clinical situation to reduce immunosuppression. So let's say if somebody gets admitted for BK, right? Or outpatient, BK or CMV, admission. So at that time, of course, we lower immunosuppression. But then they get switched to a different protocol, which is a monthly monitoring. And the reason is that if we are treating BK, we are reducing immunosuppression. But at the same time, slowly, if the cell-free DNA starts to uptrend and the BK is going down, I know the immune system is kicking up. So then what I do is that I slowly start to introduce either, CellCept or, mTORs, depending on, what we want to do, depending on the BK load and all that. So we'll slowly introduce immunosuppression and then kind of watch what the cell-free DNA does.
I see.
And that's how we have been essentially trying to use it as, an immune dial at that time, because we don't have anything. I mean, if I just go based on viral logs, viral log tells me that, it's going down, but it doesn't tell me what the immune system is doing. A viral log, if it's going down, but if your Prospera is stable, that's a good news, right? That means I don't need to really ramp up. The patient doesn't need much. But if your Prospera is uptrending, then I'm worried at that time, despite a downtrending viral log, right? So that means the immune system is active, and sooner or later they're going to form DSA. I don't want to be in that boat where they have already formed DSA.
I don't want to be behind the
Yeah,
ball curve.
exactly. So I want to be proactive and get it over there.
Okay. I love that immune dial. I think we should put that on a pen or something like that. Yeah. So let's go back a little bit to your surveillance protocol. I'm curious to know, what about the patient that maybe was transplanted 4 or 5 years ago and they've never had any Prospera? What do you do with those patients?
Yeah, so if let's say we get, patient 4 or 5 years ago from another center or, it moved, we try to do like few draws initially, at least, one draw when they come to see us, and then we'll typically draw 2 months later, Prospera draw, and another 2 months later. So we have these 3 draws to establish a baseline. So then we know what we are dealing with. And if it's low, we feel comfortable, then we can, basically switch them to every 3 to 6 months. But, for most part, what we see is that in some of these patients, there have been challenges. As you know, the patients who are further out in the transplant journey, there are more challenges. So we get these patients, with squamous cancer, or other forms of cancer. And then again, this becomes really handy information for us. So every time, these older patients, there is risk, immune suppression reduction for, let's say, CMV, for BK, for infection, for a cancer, they start to fall in this high-risk protocol then. But if there's somebody who's moving in and seeing us, we try to get that data. Because I almost feel, and maybe I'm handicapped with it now, but I almost feel I'm blinded because if I don't have, Prospera, I really don't know where in the spectrum are these patients falling, right? Are they high risk, low risk? I really cannot put my hat onto this. It's like where it is, right?
I see.
And it helps me kind of put that thing, okay, I mean, these are patients that are now in the low risk, and I feel comfortable with whatever immunosuppression they're on.
Wow, that's really useful. So would you say that this protocol has changed outcomes at your center, and if so, how?
Yeah, so we definitely, believe that this protocol has changed outcomes.
Wow.
And, the first and foremost is basically, antibody-mediated rejection. So we have been able to identify, as the case that I alluded to previously from 2017 that we did. If the Prospera is high, we get a biopsy, and oftentimes, all our biopsies have molecular microscope. We get early AMR, and then of course, we go down the pathway of treatment of early AMR. And what I have seen is that, we have a handful of these patients that we have followed, because once they are AMR, they just follow with us. And they're on, certain maintenance immunosuppression that we have optimized and increased, and, certain IV biologics that we do, and we follow them for long, and we have, 5-6 years, data now on all these patients. And what we are seeing is that it takes a long time, to treat these patients.
Sure
but
does.
the beauty is that they're not getting into graft failure. They're actually living with a functioning graft. And that's the goal of transplant, right?
Of course.
Right? To freedom from dialysis and improve survival. And that's what we are getting at. So yes, we definitely, believe that it has changed outcomes for our patients.
So you feel that Prospera surveillance protocol has led to prolonged graft survival in your patients, or better graft survival?
Yeah, better graft survival, at least as far as we can see, in the immediate. We accept very high risk kidney. Our recipients are really high risk, but our outcomes have been really, great. And I think one of the reason is, we feel like is due to Prospera monitoring, we are able to identify patients early, intervene, and have a successful, graft outcome.
Well, that's great to hear. It makes me very happy. So thank you for sharing that. So let's go back to the ProActive registry, and I understand you're an author, and it has now been accepted for publication in transplantation, so congratulations.
Thank you.
So what were you've already shared a lot of your thoughts on that, but was there anything else that surprised you about the results of the study, or did it more or less line up with what you've been experiencing clinically?
Yeah, one of the surprise from the study that, I was not expecting was this gradual increase in cell-free DNA prior to the biopsy event.
I see.
We see it anecdotally in few patients, but to connect the dots, it was really awesome to see that there's a biological process happening way before that our human minds can, wrap around.
Right.
And that was one of the really surprises for me to look at it. We see in clinic, okay, the cell-free DNA is elevation and all that, but to see this gradual uptrend is really got me thinking. And that's when, we decided about the protocol and think about, because there are these little triggers that's happening, right? And that's kind of turning the engine on slowly, and then it gets revved up, and then you get the rejection in the biopsy, right? So that was a big surprise to me. I was expecting, of course, we're going to see rejection, there'll be difference, in the values, but this trend was what was really, great to look at. And it kind of solidified my belief in the assay, because that tells you that it is upticking even prior to the event.
Right.
And that just tells you that there's allograft injury going on.
Right. I remember earlier you had said that you have often seen rejection on molecular microscope well in advance of when it shows up on BAMF histology.
Yes.
So given that in ProActive we use BAMF histology, do you think that's why we're seeing this early cell-free DNA signal?
Maybe that could be true, yeah. So, because again, you're defining the event based on histology, right?
Right.
If you were to define the event exclusively based on molecular microscope, right, then that time, 0 might have been moved, right? Just because you are now catching it really early. But yeah, again, it's how you define the goalpost, right? So
yeah. So it sounds like there's a lot more inertia to rejection than we thought. So it starts earlier and slower than maybe we used to think. And I think we've all been familiar with the post-biopsy inertia because it can be really hard to treat. So it makes sense that there's inertia pre-biopsy as well, I think.
Yeah.
Well, that's great. Very interesting. So, just to kind of wrap up, what advice would you have for someone in the audience, either a transplant nephrologist or a community nephrologist who cares for transplant patients, if they were thinking of starting a surveillance protocol with Prospera?
Sure. So my advice would be, the first and foremost thing is that this is a very, very useful tool for you to be able to assess patients who are high risk for rejection and also to be able to find patients at a low risk so that you are not worried about them and you can focus where really the focus needs to be.
Right.
Okay, so that's the first and foremost message, is it helps to immune risk stratify these patients. And that is very challenging right now with all the tools that we have, but Prospera helps us in that. The second part that I want to tell is that surveillance does help.
Right.
The reason is that, as we have seen in the ProActive study, is the cell-free DNA or Prospera starts to go earlier than the event of rejection. And molecular microscope is not that prevalent out in the community. It's restricted to mostly transplant centers. They are going out, but for the most part, most centers, exclusively still rely on histology.
Right.
And which is fine, but essentially what it tells you is that the cell-free DNA can go earlier. So you need to really optimize immunosuppression, manage them well. And it's a great tool to have, and it helps patients. And whenever I talk to my patients, did you get the box kit? The first thing they tell me, I got it and I turned it in.
Good.
Because they love to see that result where it's low and it's saying that no risk for rejection. I mean, think about a patient who's coming, right?
Right.
We tell them your creatinine is okay, but the next question they ask me is that, am I rejecting?
Right.
Can you tell me if I'm rejecting or not? And really, I didn't have an answer.
Yeah.
But with Prospera, almost with certainty, if they're low, I turn the screen to them, I say, this is your Prospera. You're not
And they
rejecting.
like that.
Yeah, they like it. They love it. So every time they get the box kit from you guys, they turn it in and they're waiting for the result. So it's been great. So
And I assume it would also apply if their creatinine's up slightly and their
Yes.
Prospera is
Yeah,
negative? Because
exactly.
they get I used to call that creatinine anxiety, oh,
Yes.
it went from 1.1 to 1.12,
Yeah,
am I
yeah.
rejecting?
Yeah.
So-
No, that's absolutely, that's another, segue where patients come to the clinic and, the creatinine was elevated and we had drawn a Prospera, and this happens, very frequently. And this was actually last week. I had a patient who got a, living donor kidney transplant, and he was doing fine. And there were some issues going on with blood pressure and all that. So his creatinine went up. So it kind of settled at 1.1, and then it took this jump at 1.7. Okay. Now this is a very well-matched kidney. Okay.
Okay.
So we're not expecting rejection, but again, you can't be sure till you
Right.
biopsy, right? So the first thing we did, we sent a Prospera on him, right? So creatinine is high. Again, we did an ultrasound, bedside, all that, the regular thing to rule out surgical issues. There was none. We kind of, adjusted some of the blood pressure medications because we thought it's one of the blood pressure medications, the lisinopril most likely with his anastomosis and all that might be causing this AKI kind of, in him. So anyways, we get that, and then, next week, so basically then we get the results later in the week, and then, he came to follow because this is in the first 6 weeks. And his creatinine is down a little bit at 1.5. So okay, we're happy about that, but he's very anxious, right?
Yep.
So the first thing he asked me, what was my Prospera?
Okay.
I said, it was 0.24. Look at the screen. You're good, right? Don't worry. We're not going to biopsy, nothing. And he just took a deep breath and he said, that's great. You made my day.
Gratifying, yeah.
So yeah.
Well, Sanjiv, you make a very compelling case for surveillance with Prospera. Any other comments before we wrap up, or?
No, I think, as I said, it's a very useful tool, and, this field is evolving, and I think the community need to embrace it and go forward with it, because it's one of those things that if you have all the tests available, which are you going to pick? I would pick Prospera, just, the cell-free DNA. The reason is that it has, a good PPV and a very high NPV for, excluding rejection or to include allograft injury.
Right.
And out of all serum creatinine and DSA that we have, this is actually the best biomarker so far. So we need to embrace it and continue, using forward.
Okay. Well, that's very helpful, and thank you so much. It's been such a pleasure talking to such an expert on cell-free DNA, and I really admire what you've been doing at your program. So thanks again for taking the time to meet with me today.
Thanks for having me.
Of course. Thank you so much for watching us today. Don't forget to subscribe so you'll receive early notification of our next exciting episode, and watch your inbox in your email for further content. Thank you.